Okay, we're doing our webinar on a different night this week. We almost always do it on Wednesdays, but I always want to say Mattas, like it is burned in my brain, but everybody else says Mattas. Mattas are always, I'm just gonna go with what I know. Um, Mattas are always busy on Wednesdays, and so we're just lucky to have Dr. Matta here with us. And so we changed it to a Tuesday, and we'll see. Maybe some of you are the same way, where Wednesdays just never work out for you. And so we're here on a Tuesday. We're glad you got the notification and you remember to be here. We're going to talk about something that's probably a big topic, but also maybe for some of you, something that you've been hearing about and listening to for several years now. It's definitely grown in the space of regenerative and biological injections. Dr. Matta is a joint specialist, an orthopedist, and we met years ago. I think the story goes that once COVID hit and everybody shut down, I was with SOTMed and O3UV, and we had to pivot real quick because I was traveling, 7 days a week, 4 weeks a month, going on location to train. And COVID hit, and I actually decided, okay, I had done a couple flights and then decided, okay, this is for real. I shouldn't travel anymore. It just started to feel awkward. And I think the mods were in the same boat where like, well, we're shut down. What do we do? So we might as well start learning about some stuff. And they were SOTMED's, let's say SOTMED's first virtual clients for teaching ozone and UV that way. And one of the things I remember is just like Dr. Mata, you were already doing so many really cool regenerative joint things, and in many ways felt like you were kind of coming backwards to ozone. And I thought, well, I
Mm.
don't know, you're gonna really like love this. It might be less impressive than a lot of the things you're already doing, even though you were very, longevity and optimization and regenerative and non-surgical at the time. But I repeat your story all the time when people come to me to this day that way. And I say, well, I had some providers specifically this way, and it was like, well, there's good things about ozone because it's fast, it's easy, it's in your office, you manufacture it right there, and you can do it on the spot, and it's really inexpensive. So it did seem to offer you a tool on top of all of these really fancy, injections and biologics and peptides and stuff, and you've really grown in your space and your field that way too. But
Yeah.
that was how many years ago now was COVID? 6?
6. Yeah.
Hmm. Lots happened since then.
Yeah. Imagine
For
that.
all of us. For all of us. All
Yeah.
right, well, we're getting a good audience here. Glad to have you all here. I recognize a lot of your names. Dr. Kinsey, so nice to have you. Really fun story with Dr. Kinsey. A lot of you have come into Idaho and been in my office. Dr. Mata's in Philadelphia. And again, we're so honored to have him here as a joint specialist. And we're going to talk about where regenerative joint therapy is today from, I think, a unique perspective. And he has a little bit of a presentation planned. I wanted to first bring up just a couple of reminders. Again, this is Ozone Train Academy. We used to be Med Masters. Before that, I was SOT still plugging away, doing the same thing, ozone, UBI, and IV training. We have this month, we have all year long Build an IV Room with Kim. It's our series. As I grow my IV room in Idaho, I wanted to share that experience with you. And if I help teach and train, it helps me get better on producing protocols and documentation, all sorts of things. And then I get a lot of people who say, well, if I was to start an IV room today, or if I want to expand or grow, what would you do? And so we have our Build Your IV Room with Kim series. And this month we are talking about ozone and UBI. We're going to go back to the fundamentals here, which might sound a little bit boring to some of you, and maybe it would be, but it's also, I'm going to bring in some new material. I'm going to bring in some modern protocols, and take a different approach to it. So I think it'd be a good reminder for everybody. And if you have, Steve and I were just talking about this, if you have new staff, if you have staff that, usually you're bringing on new staff every year, some of you every quarter is what the statistics show, every couple of years, it's always good to go back to the basics sometimes. What was the UCLA basketball coach's name? Can't remember his name right now.
John Wooden.
Yes. And he was always like, start with the basics, tie your shoes. Like we got to get through the game with your shoes tied. So it's always good to go back to the basics, but I am going to bring in some new materials. So that is our masterclass,
Mm.
Build an IV Room with Kim series this month. I want to say Holly's probably going to share it in our notes, but I want to say it's the 30th. It's a 3-hour course, and then we'll provide a lot of documentation and stuff after that. The second thing is our next neural therapy. Steve, do you do neural therapy? Yeah, I know you do
Do I do
Stelly.
neuro? I do
Yeah,
neural. Yeah, I did
the
neural
other
today.
stuff.
Hmm?
Okay. We're doing neural therapy and ozone EBU training. We have the 3-day sprint, if that's what you call it,
Nice.
in Idaho. So we've combined the neural therapy with the EBU. If you want to do both, if you want to do one or the other, you can definitely come for one or the other. But I co-teach that with Christina Finnerty, who is a phenomenal teacher and practitioner here in
Mm.
Idaho with me. So we have that. That's like May 14th, 15th, and 16th. And I think we just have 2 spots left for that May class. So that's where we're focused this month is on those 2 things. And I just wanted to remind you, bring that up. You can definitely check our website, Ozone Training Academy. If you're interested, if you have any staff interested, if you have any colleagues interested, please share that information with them. Okay, Steve, thank you for being here.
Time?
Yes.
Thank
Um,
you. And yeah,
well, I was going to say, tell us your version of, I mean, that's a little bit of how we
not
met,
bad.
but tell us a little bit about you.
Yeah, and by the way, I'll make it if no one's heard me talk before, I'll make it easier on the pronunciation. It's what's the matter? So we always
Ah, okay,
I
okay.
always say I was tortured
You've
on the
never
playground.
personally corrected me before, so you must have
You
just been
know,
like, it's Kim, we'll let her
it's
do it.
funny. Even our head nurse Caitlin, even last week I was hearing her say Matta, and I corrected. I realized I corrected the other 2 nurses, and I didn't correct her, and I still haven't corrected her. But I always lead with what because she's heard me give this like pitch at whenever I teach at conferences, and it's like usually a good icebreaker for me to say, "What's the matter?" And then everybody knows how to say it. So,
I know
um,
it too. It's just it's so ingrained in
yeah.
my head the other
What's
way.
the matter? Yeah.
Yeah, I do
Now you
know.
remember it. Now you remember it. That was by the way, and here's a little plug for you, Kim, because man, you're right. It was a very chaotic time, uh, obviously for everybody, but we were in trouble. I mean, like everybody else, had already been doing IVs, had been really considering ozone, and then yeah, I mean, you guys, you offered that virtual training, and yeah, we were able to get set up, and that, I mean, the rest is history. I mean, ozone, I mean, more than complemented what we were doing. I mean, yes, I was able to add the ozone injections to what I was already doing, which in and of itself was phenomenal, but you know, eventually getting set up with, just what we call our tier one, and then tier two, and then high dose, and then EBU, and it totally changed everything. It totally allowed us to survive. I mean, this is like I wish that we were on stage and I could make everybody clap for you, Kim, because you like really super duper made Meeting Point Health happen. So very, very thankful to you.
We
Um,
did a lot of work together. We did the initial, you bought the original equipment. We did the
yeah,
initial stuff. You guys, we were just chatting about this beforehand, but you guys ended up going through quite the shift in your staff
yeah,
and even your location. You've moved on and you've got a new
right.
place. But we did a lot of work in terms of some coaching, some consulting, some building treatment plans and packages. But you guys were such great students to just, and COVID probably allowed you some of that space and time to do it in real
Yeah,
time.
it
But
did.
you guys were
Yeah.
so driven to improve your practice all the way around, and I know you still are. And we're going to
Still
have
are.
his wife, Mary Ann, on here soon because they're both part of our board at Ozone Train Academy. And we were discussing last night, she's going to discuss some of that business part of things. But really quick, before you do your presentation, like not as a plug for me, but as a plug for ozone and maybe ultraviolet
Mm,
as well. Like
mm.
truly, what would you say were the top 2 or 3 things that it really did to transition your practice?
What Ozone did to transition?
Yeah, yeah, whether it be from the injection side, the IV side, like why do you think that seemed to be such a key factor? Or what?
Um, Well, I definitely would say it really brought in a treatment for chronic Lyme, to be honest. Like that was something that we were already starting to treat. Marion was trained from IFM. We were seeing some Lyme patients. We were doing the herb thing. I think we had done a little bit of vitamin C thing. But we were really able to treat chronic Lyme, chronic viral stuff. I mean, we weren't treating acute COVID, still don't. But it gave boosted performance. We very quickly started what we call the trifecta, where we were using, sort of like our version of a Myers tier two ozone, which so that's our Tier two is the like 60 mLs blood plus whatever 180 ozone with the UV light. So and then glutathione. And so that just like started like helping people without really knowing what was going on. So it really boosted our IV practice without a doubt, without a doubt. Orthopedically, it pro just like already doing PRP, but then adding in prolozone kind of gave this uh what's 89 gas, anyway, like this, like, middle ground option to just help decrease inflammation, get people out of pain. And then yeah, and then like ozone did other, like, we had rectal insufflation, and we had the boo stuff, and ozone water, and so it just like made things more versatile. But without a doubt, like, still ozone is our workhorse. I mean, like, it's phenomenal. Like, I mean, it just can do so many things. There's so many times that I'm like, I'm not exactly sure what's going on with you, but I'm pretty sure ozone will help, you know? Yeah.
So one last little question is just, do you still do, you always go through those tiers to get to Ebu?
Oh no. No, we
You
don't.
don't.
Like, you're saying, like, do I always graduate
Dosing, titration, yeah.
Edabu?
Yeah.
Um, no, I wish, I don't know if others are, but we definitely have, but if we do try to at least do the high dose before Ebu, or at least I prefer it. I still really, really, really like a high dose. And we'll sort of mix and match with Ebu. I would say we have a lot of interest in Ebu. I'm sure you hear this all the time, but people, and I don't know if there's another Ebu around here. So we're definitely, even if they are, I think, anyway, I think we do things very well here. And so we get a lot of Ebu traffic, and I actually feel like Ebu is quite safe. Even though it's a lot more ozone, I actually feel like Ebu is quite safe. We rarely have issues, and I don't think we ever have issues. So I don't really feel the like, oh, it's too much at once type of thing, because we've been doing it for so long, we haven't had those problems. So,
You were one of the practices that graduated through
oh
or
yeah,
involved in therapies with us was like the standard major
oh yeah,
autohemotherapy with UBI,
yeah.
and then you got the high dose system, and then the EBU became available. And I was the one, I didn't do a lot of personal trainings on EBU. We had like 9 staff at the time, but I went to Philadelphia and trained. You were one
We
of
we
the
like that
first.
was part of the deal, Kim. We're like, we're doing Ebu. Kim's coming to train us.
There was a few, and I went back to back. I was like in San Antonio, Houston, I think, for a big conference there I was speaking. I went straight to your office. Then from your office, I went to Australia for the same thing. It was
How
like just
about that?
these like VIP people. I was like, okay, I'll do a couple of cool things for cool people. And then we had people go out and do it. But yeah, you evolved through it. And
Oh
so
yeah.
you had all three and you have all three. But there are
Hmm.
a lot of providers that just went to Ebu. And so they don't
Hmm.
have the standard and they don't have the high dose, which is kind of
Hmm.
why I'm kind of revisiting those things
Hmm.
in the master classes this summer because
Hmm.
there's differences. And I love that you just said, like, I still love the high dose system. I still love it for certain conditions, or maybe your own self, or maybe for performance, or maybe for acute infections, whatever you use it for.
100%.
Like, There's still a
Yeah.
place for some of those other
Oh,
therapies.
yeah. It's not, I mean, honestly, it's not always just a cost thing because, I mean, I'm talking about stacking today, but you know, there's a time aspect, right? Like if someone gets high dose, it's going to take a little bit longer. Obviously, Ebu takes longer. So we still stack on top of that. We still will do multiple IVs in addition to Ebu, but it's a little bit easier to add on like once again, our tier two and then add on a Myers and then on an IV peptides or plus glutathione and plus our pH bag or sodium bicarbonate. So yeah, I still love all the above. I personally, um, because I get IVs here every week, and I'm more of a tier two. I'm too impatient to sit even for a high dose. I know that I shouldn't be impatient because I have to teach my patients to be patient. But it's fun. All right, so I'm like, do I like save this for myself or do I share this? You know what I discovered? I'm so curious if anyone else has picked up on this. NAD, right? So NAD, you get the flushing. It feels like crap. You want to keep a vomit
Hate
bag.
it.
But if you run ozone first, and it, like I want them to like I try to do it too fast, and like especially our staff now, they're like, Dr. Matta, you got it. We're not doing it this fast. And I'm like, you're doing it faster. But but I learned my lesson because last time I ran it real fast. But if you run the 60 mLs or whatever slow and then do NAD after, I can do it 5, 10 times faster.
Really?
I think there's something with the oxidative factors from ozone and the NAD that allows you to not feel the side effects of NAD. Like I
What
can
dose
run
of
a
NAD are you
show.
doing?
What's that?
What dose of NAD do you prefer for tier
Like
two?
250.
Yeah, okay, interesting.
But I could go to 500. I did a 500 one time and I can run that. And if I do like more ozone or if I do it slower and then I can run that really fast. I think what's the little thing that they attach to see the drip rate? I think it's at like 500, whatever that number is. So it anyway. It 100%. The one time I didn't do ozone before, I felt the same flushing, but doing ozone first definitely makes a difference. Now I
We're
don't
gonna
know
have to
if it's the
explore
same with
this at some time because the only time I've seen NAD go fast is in a hyperbaric chamber. There's a practice in Utah and they've got these massive hyperbaric
so I
chambers.
think it's probably something similar, right?
Maybe.
I think it's something similar there.
Yeah, like something
Ozone.
to do with driving oxygen. I don't know. I mean, but what's so they could even put somebody on a liter, or sorry, well, a liter, but 1,000 milligrams of NAD. And they didn't do ozone first, but they did the NAD, like they were in NAD practice in hyperbarics. And these people come out in 2 hours with not a lick of side effect or that, feeling. And that's the only time I've seen somebody be able to really drip that fast unless they could just tolerate a lot of discomfort. But
Yeah.
I have one other experience with NAD. I don't think he's on here because he's texting me right now, which is weird. In another practice in Utah, I was teaching Ebu, and we had done his high dose, a practitioner, and then we pushed a little NAD. And I'd have to ask him if he remembers the dose, but it intensified that
Yeah,
cardio
of course.
tightness. And it was like I mean, if he wasn't a provider and we weren't providers that trusted his analysis of what was going on in his body, we would have called the 911. It was it was intense. I mean, he
Oh
was like, I
no.
think I'm dying. I think I'm dying. No, 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 don't call anybody. I'm not dying, but I feel like I'm dying. And so those are the only two like real adjacent. My colleague, he's got some
Yeah.
experiences of doing NAD with ozone. And so we've said don't do it. Like if there's anything you don't want to piggyback with Ebu, and probably any ozone, it's NAD. So it's really interesting you say this. We probably just need to do more of it or explore more of it. Or maybe, we saw
Now, why
some
do you say that? Why do you say not to piggyback any D with
because
ozone?
we experienced that like the
Oh, because it pushed
intensity,
it
it
too fast.
intensified the NAD, not the other way around. The only other time,
I mean, like this isn't once. This has been like I want to say seven, 8 times, the last 7, 8 times,
okay,
and
we're gonna have to
like that.
nail down exactly what you're doing and the speed you're doing it. I'm
Maybe it.
talk to your nurse.
Trying to think. I do want to. I we do glutathione as well, so maybe it's the ozone plus glutathione. It's not just the glutathione though, because I know I got glutathione and then um, I got I got glutathione alone and then just the NAD because I was trying to rush, but then it ended up being slower. Literally, like the time it took me to do ozone and NAD because I can run it faster is faster than me not
NAD.
doing ozone.
Huh. Yeah,
Yeah.
we'll
So
have
I'm
to
so curious if others start doing that and if they
yeah,
have the
if
same
any of you have
experience.
experience with this and you're listening and you have access to the chat, write it in there and let us know what your dosage is of what your experience is. And again, we've been teaching don't do it back to back, so I don't
So
know.
funny.
I don't know how many people
So
might
funny. But it
be
was just
the
because of the push thing.
Niagen. Have you done the Niagen?
Oh, I'm so curious to get on Niagen. No, I
Yeah.
just talked to somebody last week about that. I really want to do it. I, I think we're trying to get set up, but yeah,
Yeah, I that is different. And I think that a lot of people have had good success with those back to back, but
yeah, yeah.
all right. I
All
wanted to
those.
ask one other question just to it's more of an intro to you, but you and your wife both practice together. She is a functional medicine provider with gobs of really interesting credentials, and yours is a little bit more, standard, and hers is really interesting. And we'll meet her shortly, I think this summer in August. But so you've got this combo between you two as providers, but give the audience a little bit of like range. What type of practice do you have? What type of patients do you see? Because I think last I knew it was like athletes, even like very high level athletes, but then you just mentioned Lyme disease also.
Yeah, I mean, it's kind of this spectrum from the really, really sick, yes, chronic Lyme, just chronic toxicity, right, for sure. Like to the super high performance, absolutely, and everything in between. Um you know, one of our, one of our biggest values is we believe you can reach your creative potential. So um, I mentioned that because one of the things we really look for is for that person to really want to get better. So yeah, but like for patient population, yeah, I mean like today, we go from everybody from someone that's, not able to work, really struggling, but trying to get better and looking for answers to, how do I, what peptide nootropics do I do to super focus to I just did 12 stem cell injections on this patient with back pain and rotator cuff. So like it really is all over the board because with the peptide stuff, we definitely have peptide focus. We have people coming in just for EBU. So we do a range of stuff here. It's a fun operation. I mean, my boards is in family medicine, sports medicine, stem cell therapy. But then like I do, a lot of movement stuff. I work with golfers with Titleist Performance Institute. But and then Marianne tends to I call her the gut queen and the mold queen because she just like I even had a patient today because of the like I'm more of the peptide focused provider. I She does more of the gut stuff, but like he had a lot of gut stuff, so I ended up I said, okay, I'm going to try to treat your gut, but there's a good chance that you're going to need to see Marianne because she's the gut queen. So yeah, yeah, great.
Is there a joint in the gut? Then maybe we can
Yeah,
go.
right. Yeah, exactly. The
There
gut
are a set
joint.
of
Love
bones
that.
in that area, then maybe I
Yeah,
can.
yeah, yeah. I
You
mean, I
injected,
know
I
a thing or two, but
I know you do. I know you do.
yeah,
You're both so well-rounded in so many ways and complement each other. When I was there, you did my hip, I believe. That's was the
SI
thing that
joint, right?
still is the thing. Um, I
Mm.
was gonna ask you, like, do you think that anyone's really that well at this point? I mean, we talk about longevity, we talk about regenerative,
Mm.
but then there's such a gamut, and it's like we even say performance and chronic disease as if an athlete couldn't have Lyme disease or something. And it's just I feel
Well
like
said.
is there really anyone
Mm.
that healthy anymore? The pandemic definitely, in my opinion, changed physiology.
Yeah.
And I'm guessing you're doing joint injections, regenerative injections, XYZ on even people because one of the main symptoms of Lyme disease is joint pain. I mean,
Yeah.
it's definitely one of the top five. And so
Yeah.
I'm guessing
Yeah.
you're doing your thing on her patients, and
Yeah.
vice versa.
And you know what, especially these high level athletes or former athletes, like especially what we have a lot of right now is former football players with, guess what? TBI, right? Like brain injury. So we see a lot of that right now. And honestly, it doesn't have to all be from just football that's going to be your classic head injury, but see a lot of like car accidents or, people have the craziest stories like got hit by a car when I was 15 or, got clotheslined by, some sort of, wire line when I was 18 and we goofing off or something like that. So a lot of people have head injuries from a young age. And, I was, toxicity will open up a previous injury, especially like Lyme is. I find this. We just had a patient today, and she's like, I get this shoulder pain in here, and these headaches, and this numbness in here, and I'm like, you had a head injury because, and the Lyme will sort of attack this connective tissue that's been previously injured. But yeah, absolutely. Like you're right. Like there's no such thing as a super well person. I think everybody's got something that they're dealing with, and yeah, I mean, I feel blessed to be able to, especially like you said, like this musculoskeletal. It can be achy Lyme, or it can be like, yeah, I tore my meniscus, and or it's just patellofemoral, like you don't know. So I like that I have kind of both wheelhouses where I can say, listen, this definitely seems musculoskeletal, or this definitely seems systemic, and we can do some testing and treat both. I think you
Yeah,
can
I'm guessing that's
put
part of
in
your
stem
stack.
cells, and why not treat both?
Yeah.
So,
Yeah. It's funny you bring up other sports because my daughter plays college volleyball, and right now they
right.
have two players out with TBIs, and it happened during volleyball. It was like,
Yeah.
and I'm thinking, what, like, how does that happen? But it does in weird ways, right? There's actually
Yeah.
someone on I think it was Texas A&M that won the championships this last year for volleyball, and they had a player who had like seven TBIs in 1 year, and so they sidelined her, they benched her. They said that she'd never play again, and she wears, if any of you have followed it, volleyball's become a big sport now, so maybe you do. She has a vagus nerve stimulator that she
Yeah.
wears around her neck when she plays. And she said that is the thing that helped her recover. That's the thing that it keeps her circulation open. And I just, again, I hear that and go into neural therapy and
Yeah.
just the thought
Oh,
of that the autonomic nervous system is so respondent to injury and infection, and that then sends pain signals and deals with, cognition and regulating your temperature and blood pressure and just some of these basic things. And it's like it's could be just an injury that then some
yeah.
infection gets a hold of. So many tools, so many good things.
Yeah,
And
I
of
talked I mean, I'm not sure if I'm allowed to give a plug for anything else, but like this was
course,
my talk at SSRP Peptide World Congress. So I think if you purchase the Peptide World Congress, which I think they're available from SSRP last year, you can see my talk, and I addressed all this stuff, like because I still deal with my sort of TBI stuff, and we have like a stack, including like IV peptides, methylene blue, cerebrolysine, like. It's super important. I mean, like because of my personal issues with it, I'm very, very passionate about chronic brain stuff. It's super, super, super prevalent and super necessary to treat for sure.
Yeah, I feel like if you don't, and from every angle, even at a cellular level, then you'll just end up, missing. You
100%.
just won't get them super well. Okay, why should people be listening to you? Tell us a little bit
Right?
about who you are and how you got here, and then we'll get into the nitty-gritty.
Yeah, yeah. So, mentioned my background. Biggest thing for me, just like so many of us, right? Like finished sports medicine fellowship after family medicine, and honestly, I didn't even get through a whole year of conventional medicine before I realized like this isn't this isn't offering me the answers. I don't understand why people have back pain. A steroid injection just feels like a crappy solution for any shoulder pain or knee pain or ankle pain or whatever. And I don't really know what's going on. I started running and having my own heel pain, and then acupuncture got my heel pain better, and I had learned functional. It's got a functional movement test from actually a strength and conditioning coach, and I'm like, how come I don't know this stuff? I'm supposed to be the specialist. That really drove me into functional movement, medical acupuncture, regenerative medicine, peptide therapy, and honestly, some integrative and functional medicine myself. And so now I've been doing peptide therapy also for about 6, 7 years. We do IV infusion therapy. I teach with SSRP, which is Seed Science Research and Performance Institute, and really very, very passionate about this kind of medicine, passionate about regenerative medicine, peptides, cellular health, and treating the whole body. So, yeah, you mentioned my wife. We're madly in love. We have a great practice, great team here together, and we're just trying to offer a great solution for people who are dealing with chronic stuff. So, and
Yeah, I love.
should I launch
Yeah,
the?
figure out how to share your slides. They're in Philadelphia. They've taken this like super old American building and turned it into a really cute IV and functional medicine practice. It's like the brick looks like it was the cobblestone with George Washington, and yet they've got this really fantastic staff and all the cool services, even a kind of a kitchen inside, and I don't know what other things you might have added, but just a really great practice there. Um, and
How are we doing?
Yep, you're getting there. We can see all of your slides. We can see that screen. You can switch screens and maybe, yeah.
All right, now you know who I am. So let's talk about, I titled it Stacking Peptides and Procedures, but it's kind of like this whole approach. And I'm going to tell you about why this is important to me. Because, listen, when it comes to getting people better, we have got to do a better job of making sure that we have good outcomes at the end of the day. So, the birth of this talk came from um, talking to docs that I respect and have been really admired in the regenerative medicine space, but their approach to treating with regenerative medicine is just like one shot once, and that should be enough. And my feeling in my own practice is that no, we need to provide the best opportunity for good outcomes. So this is more than just like this goes beyond, the conventional approach is going to be, let's just talk about back pain or whatever. It's going to be, oh, you have a L4 or whatever, and let's just put an epidural in there, or you have a rotator cuff, tear. Let's just put a steroid in there, or let's just throw gabapentin or some NSAIDs at it. Um, like this is more than that because I'm talking, okay, this is now let's get into the regen world. Okay, well, we're not going to put a steroid in there, but we are just going to treat it with one shot of PRP once and done. We're not going to really look at everything. Um, I think the problem is that there's so much more going on, and we're going to get into that. But the way I approach this is I treat multiple areas with multiple injections, treating multiple layers, and then I add on peptides. We also use ozone. We use like MAH, like our what we call our tier two, tier three, and EBU. But I also use shockwave, and this abbreviation NFA is neurofunctional acupuncture, and I'll get into what that means. But kind of this stacked approach to offer the best possible outcomes. So we're not just like being, one shot docs. We're actually treating the whole system. Um, Let me talk about myself here, and this is a big thing for me is that about 18 months ago, I myself was my own patient. Honestly, I was dealing with this like chronic neck pain, chronic low back pain, and not really able to do what I love doing. I love mountain biking, but I'd go biking and I'd be in pain. I love golfing, but I'd golf and then I'd end up with neck pain. I wasn't able to lift, honestly. I wasn't doing push-ups. I wasn't doing any core exercises because it would always flare my neck. So I decided, you know what? I'm done with this. I'm gonna really focus on Steve. And I got myself. I had a friend of mine treat me with stem cells in my neck, in my facet joints of my neck, in my low back, in the facets, and the SI joint, the nerves. I got a lot of stem cell injections, but then I added on my own. Guess what? Peptides. I really stepped up the BPC 157, and the TB 500, as well as the growth hormone peptides. I got consistent with my IVs and on combination of high dose ozone, EBU, NAD, IV peptides. And listen, today I feel really good, honestly. Like I'm able to work out better than I ever have. My mountain biking is fantastic. The golf game has nothing to do with my pain or my strength. We're getting there too, but the golf game is better. And I'm just like, I'm able to get through things. Honestly, I like the way I look. I think Marianne likes the way I look. And it's just, I talk about moving from pain to performance. And so, that really got me thinking, okay, we really love to just share this with other people. Um, and this is our protocol. This is all three of these are very important to me. Assess, inject, correct. Assessment, this is my jam. I'd say, without bragging, one of the things I think I do better than most providers out there, most providers treating musculoskeletal pain, treating pain is I do a really, really, really strong assessment. Functional movement screen. I watch gait. I do like muscle pattern testing. It's not just kinesiology. It's just like how are the glutes firing? How's the lats firing? Very, very big on tissue palpation, joint testing, obviously, nerve testing. We look at the whole body, look at the whole area with ultrasound, and then we get into the cellular testing as well. So you have to know what's going on. You have to know where the pain is coming from. I do injections. We use biologics, PRP, MSCs, exosomes. I chase things with ozone, and I inject peptides. I do hydrodissection with peptides, and I prescribe peptides for home use as well. And then we correct. So what was the root cause, and what are we doing to address that? So you have to inject like I needed injection, but then we have to build on that so that we can get back to our function and activity. So correcting is shockwave therapy, the acupuncture that I do, and then hopefully getting someone into good strength and conditioning protocol. All right, so this is why it's important to treat everything because we're not just like discs. We're not just lumbar discs. Like pain is more than just a disc. You have the joints. So in the back it's facet joints. In the knee, obviously, you have the articular cartilage. In the shoulder, same with articular cartilage. But then we have kind of the extracellular matrix and connective tissue just beyond that. Like we have capsules around joints. We have all the fascia, the tendons, the muscle, connective tissue just outside of that, like ligamentum flavum, posterior ligamentum complex in the spine. Obviously the structural ligaments that keep everything together. I mentioned the fascia, and then we have nerves and nerve plexi that innervate muscles, innervate joints, innervate fascia, innervate, and we have the autonomics. We were talking about autonomics, and then the systemic and cellular components, and all of it needs to be addressed. You can't just put a PRP shot in and just say, "Oh, okay, good night." Well, what about the ligaments? What about the fascia? What about movement? What about the cellular health? What about what's the oxygenation, the perfusion like in the area? How are we addressing that? So let's talk about peptides in this whole approach. BBC 157. You should be annoyed about how much you're hearing about BPC 157. If you're not studying peptides enough. If you are, it's good to like go back over it because it's a phenomenal peptide. Why? And these are just a couple things. I'm used to saying pain, inflammation, repair, but getting deeper into it and honestly going through this talk, it's kind of highlighted a little bit more about these peptides. But you look at these. We improve VEGF receptor upregulation and the AKT enos pathway. So what are we talking about? You're actually helping endothelial cells. You're helping perfusion, and you're getting better oxygen delivery. So we're not just putting stuff in, but we're also helping to oxygenate that area. The ERK1 2 signaling, we're helping that fibroblast proliferation. So once again, we need that cell-to-cell communication. I deliver that PRP or that stem cell, and we want to help that stem cell or PRP talk to the fibroblast for recruitment and healing. And then there's serotonergic, dopaminergic pathways, and also helping with pain modulation. But listen, at the end of the day, it's helping that environment be better for injections. TB500 and GHKCU. So TB500 is, they talk about BPC 157, TB500, thymosin beta is also thymosin beta 4, the Wolverine stack. But let's just talk about TB500 in and of itself. We're helping that cytoskeleton. We're helping that structural elements of the cell. We're improving NRF2, decreasing inflammation. We're opposing fibrosis. So anytime there's injury, fibrosis wants to happen, will happen if you do nothing. And so that antifibrotic activity helps to kind of protect. So where there's injury, we want to revascularize, but then we want to protect from things going scar tissue all over again. And then angiogenesis, forming new blood vessels. These are microcirculation. So once again, the BPC opened up some of that vascularization. The TB500 complements that, helps with that connective tissue. GHKCU is really, the copper peptide is like, we think about it for aesthetics because it really works on that collagen. It's great for wound repair. It also helps stem cell activation. Go figure. Also works on nerve and antioxidant and nerve fiber regeneration. So once again, when you're treating around the joint, when you're treating the back, you're dealing with nerves. You need that neuroprotection. And so I love using all three of those. Those are a great sort of complement stack to my regen. Um, and then growth hormone peptides. This is super huge for me. Now, it's easy to think about just growth hormone peptides, and I personally love tesamorelin. That's my growth hormone peptide of choice. There's also CJC 1295 with ipamorelin. There's hexarelin. But it's not just bulking up. I see a ton of just muscle atrophy. I just treated a patient a few hours ago, and she had this huge spine surgery, and she's just like glutes are atrophied, calves are atrophied, and she can barely walk. And so even though we're doing the neurofunctional acupuncture, we're adding on the growth hormone peptides because strength protects from pain. Tightness is weakness, and we need to rebuild those muscles. We need to rebuild the multifidi, the rectus spinae, and the spine. We need to rebuild quads and glutes for strength to protect against re-injury, to get more movement. So this is not just bulking up. It's great. It's nice to get lean body mass, but we also need growth hormone to once again help repair, increase protein synthesis. And it also helps that IGF-1 release that you also get from PRP. I made a note on the last bullet there, this safety profile. Here, I talk about this with my patients all the time. Here's the beauty of peptides. Whenever you're in dealing with pharmaceuticals and they're on, Lexapro and Xarelto and metoprolol and all these pharmaceuticals, and this just drive me nuts in primary care where I'm like, oh my gosh, how do I deal with all these freaking pharmaceuticals? Because if I add this one, then I'm going to have this side effect, and you're going to have drug-drug interactions. The beauty of peptides is that we can stack them together safely without interactions, and they complement one another. And I can go up on dose without affecting anything, and it's safe and it's great, and I can do it all together. And I just love that about peptides is that they're cellular molecules already in our body, and our body knows how to use them, and they're super duper duper safe. And one of the things I love about peptides. So, got to talk about ozone here at the Ozone Training Academy. We talked about ozone a lot at the beginning, and I'm a big fan. And so, some of the biggest things ozone does is work on that microcirculation. Ozone helps that IV ozone and even local ozone helps that red blood cell flexibility, like getting into those capillaries and helping to get oxygen delivery. A lot of chronic pain is that avascular situation. Tendons don't love to heal because they're avascular. And so, once again, we have the BPC 157, thymosin beta 4, angiogenesis, enos, and ozone comes and helps that RBC flexibility, helps drive oxygen delivery to the tissue via the ozonites. And it helps decrease MMP, so matrix metalloproteinases, which unfortunately degrade the joint. So ozone helps to block that. It can help post-injection pain and works on gene upregulation. So I love adding ozone. I'll add ozone with my PRP. I'll add ozone with my stem cell injections. What I'll often do is, I mean, I do sometimes like to get some ozone right in that facet joint because it really helps the joint. Because it kind of screws up your ultrasound a little bit, I'll only add a couple of mLs, honestly, with a PRP or stem cell into the joint. But a lot of times I'll chase my injections. I mean, they've already been numbed up, and I'll just kind of add ozone at the end to kind of what I call bless that area and really help to. One of the greatest things it does, and there's great studies on this, is that it helps that multifidi activation. Multifidi, particularly with spine, gets downregulated, gets atrophied, and that is a big, big contributor of chronic low back pain and poor movement of the low back because those deep stabilizers are super duper important. But I definitely like any knee injection or shoulder injection. I just love to chase it with ozone because it helps to release those growth factors. I'm going to talk about other things I complement with these regen injections. So adding shockwave therapy. Shockwave therapy is fantastic for a few different reasons. Another one of these sort of circulation things, it brings in VEGF, so vascular endothelial growth factor. Once again, helping that new blood vessel formation. It amplifies the stem cells, so it helps fibroblast recruitment. It's that endogenous stem cell homing. So it's like, hey, stem cells, make sure to come here. And so, a regen injection like PRP or stem cells is is a homing signal in of itself. Now, when we add on shockwave therapy, we're amplifying that signal. And a lot of regen is, PRP is talking to fibroblasts, so we really want to boost that response. We're doing that some with adding in the peptides. We're also doing that with adding in shockwave. And it's just great in combination. I do. I do neurofunctional acupuncture. What's that? If you're not familiar, it's a multi-system approach to acupuncture. I'm not, and respect to all those traditional acupuncturists out there. I love what you do, but I'm not dealing with chi or meridians. We learn that, we understand the channels, but I'm treating the nervous system from a central, spinal, systemic, and local treatment. So I treat the motor points, I treat the spinal segmental points. And so if I'm dealing with like a low back pain, I'm treating all the way from like T10 to S2. I'm treating the glute points. I'm getting the glutes to fire. I'm helping that deeper multifidi activation and getting better movement, because one of the biggest things I see is that we've treated the area, and now okay, we've gotten healing and repair. Are they ready to move? No, they haven't been moving in a long time. And this is the same thing with lower extremity, shoulder, scapular thoracic complex. That we've gotten repair in there, and now we need to get things stronger. And so I add in the neurofunctional acupuncture to get some strength and neuromuscular activation, in addition to shockwave, and then plus, oh, guess what? We have those growth hormone peptides to get some hypertrophy in there on top of the activation, and now they're ready to move. And that's that correction that we were talking about. So we bring in the regen, we complement it with peptides, we complement it with shockwave, and we complement it with neurofunctional acupuncture, and then they can get into that rehab. And guess what? We still have BPC and TB500 to help any recovery, in addition to the growth hormone peptides, to help recovery. And at the end, now we have a patient that's going like me, from pain to performance. So it's not just getting out of pain, but so many people. I know, Kim, you're super active, and it's like you don't want someone just to inject. You want to get back out there and run and be active again. And me too. Like I love mountain biking. I love golfing. I love being active. I love just working out. And I don't want these discs or these chronic injuries to get in my way. I want to be active. And so that's what I love about adding in the neurofunctional acupuncture. Um, IVs are super important. Addressing that cellular dysfunction, once again, that's going to boost the mitochondria. At the end of the day, EBU, NAD, Myers, glutathione, ALA, you see all these infusions on there, and we're really, really working on, you see mitochondria in this slide over and over again. We're improving oxidation, we're improving mitochondrial health, we're improving nutrition, all these building blocks, because we're either preparing, I do these we do these IVs in preparation. We do peptides in preparation. We do them during, literally they get an IV right before, they get a PRP draw. They get a Myers while the PRP is spinning, and then we go and we do the regen. Happens in my office every single day. And so we're supporting that process. I mean, you need a healthy immune system to get that PRP to get recognized, and then there's nutrients involved in that repair. There's NAD is like a currency. I think of it like crypto, honestly. Like, it's a currency that is going to get consumed in that stem cell differentiation, that stem cell recruitment. It needs a lot of ATP, needs a lot of NAD, and so that either comes through ozone and or NAD. Matta C is a great pure NAD recycler. Glutathione, ALA are all supportive of all this. Uh, and then this is it in summary. So this is our stack. We have our PRP. We talk about adding in the ozone. We have our peptides, IVs, PT, strength and conditioning. I'll just talk about a quick case, and we can get to questions. This is I love these cases. And I'll just mention it. So, 44-year-old guy came in, like, showed me his L4, L5, like disc herniation, legit disc, pinching on his spine. He had prior to he had this like nasty car accident. I actually think he got hit by a car in a parking lot. And actually had a head injury from that, but I think that preceded, and he was just working out a few months later and lifting, and pop goes a disc, excruciating pain. And before he came to me, went to conventional ortho route, got multiple epidural injections, was on high doses of gabapentin, and was going to go for surgery. Honestly, that was the next step. And heard about me through a friend, drove the 2 hours to come see me, and did our assessment. Found once again a few things. He had some poor activation of his low back muscles. He had other things involved. The glutes weren't firing. He had some right glute pain, so superior gluteal nerve was getting entrapped. And so first visit, there's not much we can do, but we treated that superior gluteal nerve. We treated the dorsal root ganglion. I was able to do a caudal on him, and we treated some of those glutes, and he felt even a little bit better. Next visit, I think it was a week later, we added on some stem cells, orange gel-derived stem cells with EVs or exosomes. So treated the facets. Actually, I treated, so T10, T10, 11, 12, L1, and then L4, L5, a caudal epidural. Also gave him some cerebral lysin around his glutes. Actually, I injected around nerves as well, to superior gluteal nerve. Repeated that, I think, one more time, from day one, we put him on home peptides of BPC, TB4. Actually, he got GHKCU. I didn't mention that in there. And then he was on CJC, ipamorelin, 5 days on. Also, penicidin polysulfate. I didn't get a chance to talk about that. He got IVs every time he came in. And then he came back for follow up, and we treated him with shockwave, neurofunctional acupuncture. And guess what? He did good. But like, he's doing great. Like, I just talked to him. He's full workouts, doing great. I mean, like, this is what we want, right? Like, this is the ultimate thing. Like, not just to be an alternative to a surgery, but to get someone from a pain, like a disc, like a legit difficult problem. And he healed like within weeks. That's not, listen, I don't promise that, but he healed very quickly because we went full stack. And so, by addressing all these different layers, we can achieve something that is really difficult. It's really difficult to treat disc herniation, but when we use multiple tools and bring it all, we're able to get someone better. So I love these cases. It brings me joy, and yeah, this is just a great case in point. So just in summary from these slides, treating multiple tissue layers, amplifying things with ozone, biologics, peptides, shockwave, IVs, and the correction addresses the root cause. It's important to have a solid assessment, and then we make sure to bring back the correct step to address what the root cause was. So, because I always have to ask myself, why won't it come back? And if you correct the root cause, then you can make sure that it stays. There you go.
What's your enter button, Dr. Matta?
Yeah, so the enter button is the program's there, right? Like, the program is already in there. Like, I think of, especially, like, I don't know, we get into this vibe coding and stuff like that. So the program is there in our cells. if you think of a baby, they talk about if, babies with spina bifida that they repair in the womb, they come out of the womb without a scar. So the code is already there to get better. We just have to tap into that code. We have to hit enter, and this is the enter button is doing the full stack because our bodies are capable of self-healing, but we just have to hit that enter button. So.
Love it. You've got some kids to take care of this evening, and we want to make sure that you get on the road for that. Do you have
Yeah.
a few minutes for a few of these
I
questions?
do. I do. Yeah.
Um,
Here, I'll
Dr. Gordine and Megan were going back and forth on NAD and ozone protocols, and I wrote this down just to make note of it. We'll come back to this at a different time. Maybe in our master class on the 30th would be a good time to get into how many syringes, how much heparin, how do you calculate the doses, all those types of things. And maybe I'll
Hmm.
throw in there like, and a few people say you can do some NAD. But
Oh,
um,
so others have said they do it?
yeah, there's a
Oh,
couple.
right.
Yeah, yeah, and had the same basic experience that when
Oh,
you do.
right. Really? That's
Yeah.
awesome. I didn't get to
So
see.
I'm gonna get some. I haven't done that Niagen yet either. I'm gonna get some though, and I'll try this. And I feel like I'm the most sensitive, so if I could do it on myself, then
Oh,
like
really?
I always tell anybody who comes in and train, I hate NAD. I love what it does. Hate doing it, hate giving it because you got to deal with all these responses in the IV room. But if ozone's the magic, uh,
Marianne's never done it. She's afraid.
see, not the only
I,
one.
I I backed off for a little bit and then I started doing it with the ozone and now I get it all the time.
It took me like 3 hours to get through 250 mils. I love the sub Q though. I love like the daily
Oh
hit. I
yeah.
I
No,
like
I do
that.
that
And
too.
so it's not that I'm against it. Again, as the person in administering IVs, it's stressful on your day to be managing all of these NAD reactions and how people feel
Oh,
every day.
totally.
So I don't love it that way either. But
Yeah.
okay, this is way back. You were talking about growth hormone peptides, and somebody writes in with what are your concerns with cancer and growth hormone peptides?
Yeah, so listen, if they have an active cancer, don't do it. But as far as I know, I don't know of any research that supports it. Yes, I understand the discussion around IGF-1 and increasing levels of IGF-1 and are we feeding, these cancers that we don't know are there and stuff like that. But I don't know of these cases that I feel like a lot of that rhetoric comes from the community that's not treating with peptides. And so, once again, if someone has a known cancer, I'm going to avoid it 100%. Um, but if it growth hormone, let's remember that growth hormone is naturally a part of our system. So peptides are only supporting growth hormone manufacturing and release. So, if growth hormone helps fatty oxidation, like it supports fatty oxidation, it's one of the reasons why it helps you to get lean. So it helps optimize the cell, actually improves mitochondria. So one of the best ways to prevent cancer is to have healthy mitochondria. The metabolic theory or whatever on cancer, I can't remember how to say that, has it also discusses the fact that cancer is a mitochondrial problem. And so growth hormone peptides optimize the mitochondria. They use fat for fuel. That's the best way to have healthy mitochondria. So I don't buy into this rhetoric that, oh, the growth hormones could possibly cause cancer. I don't hear like if I missed a study or if I missed some like very relevant cases that I'm not privy to, I don't know. But as far as I know, like and we talk about this in our training. I don't know of any legit cases where we believe that growth hormone peptides were responsible for a cancer. I think, I feel like that discussion has been planted from this community that wants to say that peptides aren't safe when they're really safe. And this question comes at me all the time, like, oh, what about cancer and growth hormone peptides? And I personally I don't buy into it. So
On the same topic, but probably a different angle, is your cycling, your growth peptides.
yeah, so you got to make sure 5 days on, 2 days off. That's one of so the um, the growth hormone receptor on the cell can get involuted if you overdose too much. So there's a couple things. Number one, I always, always, always recommend 5 days on, 2 days off. Um, CJC 1295 with ipamorelin, I'll keep them on that for a long time. Usually, it's tough for anybody to take a break, like not take a break. Everybody ends up going on vacation and not refilling, and like everybody, even my hardcore, even me, like I'll take a break. And at the end of the day, that's all you worry about. It's particularly the ipamorelin that you, yes, that is one of the things. But in anyway, tesamorelin, I'll stay on for several months. But same thing, like I tend to like I'll run out of it, and maybe I'll switch to CJC 1295. It's a little bit stronger of a growth hormone peptide, but well, some of the other stronger ones like MK677, MGF, like PEG and MGF, you do need to cycle it. Like those are really bulky peptides, like you'll really hypertrophy. You definitely like you can only do like 6 weeks, 4 to 6 weeks, and then you got to cycle off of it. And cycling off of it, you take a few weeks off, and then you can switch to a CJC. But yeah, I do not recommend cycling. You should have some degree of cycling, but the most important thing is that 5 days on, 2 days off.
This is my own interest in my own question for peptides outside of the growth hormones, GLP-1, GLP-2, GHK, whatever it is, but I am a little bit mostly intrigued in the GLPs, is the same concept of cycling. Not because it's a growth hormone related cycling theory, but just and it's truly a question to you, is there something to be said for maybe cycling through GLP-1, GLP-2, GLP-3, or even taking time off of them because of this age-old adage that your body's going to get used to it and become dependent on it, and so on and so forth?
Yeah, so number one, it really depends on the individual. But for me, um, I do like same thing. Like we go away, and I actually just kind of like that's my cycle of everything. Is I don't ever people. I have patients like I
You
should
don't
say this.
travel with a cooler
No, I
and
don't. I don't. And that's kind of my cycle. No, no joke. Like I have patients definitely have their ice pack and the da 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 da. And actually, anyway, I won't say it, but my understanding is that they're a lot more tolerant to heat than people think, but I won't say that. But I'm on Reddit and yeah, I mean like I don't need it as often as I used to, number one. So that's a big thing is when you add on the growth hormone peptides and you have hypertrophy, the insulin receptors just don't need as much GLP-1, honestly. Now, if you were at a heavier weight, if I was at a heavier weight to start with and I lost a lot of weight, there's this resistance back to that previous weight. It's always going to be there, by the way. And so maybe if they took breaks, they're probably going to start to gain a little bit of weight back, if not a lot of weight back. If they don't, also bring in strength to combat that in particular. The other thing I'll say is that let's remember that the GLP-1s like liraglutide has been in diabetic patients don't go off of it. So I don't know that we necessarily need to cycle. Let's also remember that peptides are innate in the body, so the body knows how to use them. They're not typical supplements, they're not typical pharmaceuticals, so they are in the body. But I do kind of agree with you. In general, I like to take breaks from things like, like to take supplement holidays on weekends and stuff like that. Honestly, it feels like more supplements I take a break from than peptides. But in general, like I said, like, when we go away, I tend to just, take a break from everything. I'll bring them with me. Honestly, I'll bring some stuff with me for emergencies or like I'm just starting to get achy and I want to live. But yeah.
I'm gonna have to. We're gonna just we'll sidebar this as another conversation because I've been experimenting with this the last 8, 9 months myself. In spite of di lifestyle and diet, my A1C was 6.8, and so for
What?
yeah. Anyway, so I've just and I showed up to a training in my own office the other day with three PAs, and I'm like, you guys, are we all going to be on peptides the rest of our lives? Like, is this like this dependency? It just kind of grates on me in spite of. So again, you've got to go with your kids, and I want to get to the other questions, but it's something I would really love to pick your brain about, just in terms of maybe what are the
Like
long.
2 seconds on that answer. Because I get this with testosterone all the time. It's like, what do you want? Do you want to feel good and take something that's safe, or do you want to deal like this once again with testosterone? It's a lot bigger thing. It's like, do you want to feel like crap the way you used to feel before you got on this stuff, or are you just like okay with dependence or whatever you want to call it? That's sort of like having to use it, but yeah.
Maybe there's something in the back of this that's a little bit conspiracy minded, where I'm just like,
Right.
why doesn't diet and lifestyle work anymore?
Yeah,
How
I mean, like we're
can't
not 20
manage
anymore,
things.
and we have toxicity, and we have decline in youth hormone decline, and peptides decline. See, this
Did
is
you just
like,
call
why
me
do we
old?
even need peptides if they're in our body? That's because our stores, like, you lose your thymus gland by the time you're 80. So why do you need thymosin alpha 1 and thymosin beta 4? It's because you don't have a thymus gland anymore. So like your store of thymus peptides is definitely decreased. So,
Dr.
I think.
Hellman's making fun of me. It's true. I weighed 120 pounds. I've worked out my entire life and I've lived like except for Christmas and Easter, my mom's cinnamon rolls. Like I just don't eat bad. And it's been my entire life. And it does run in by dad's family, but it doesn't make any, my dad's A1C was 11.8. And he went on Ozempic. And that was something interesting too. He still looks like he's on Ozempic. He's still, it doesn't, his blood sugar's creeping back up and so forth. But the genetic component, okay, maybe, but still, this is not a new lifestyle for me. This is not something like it's just a really interesting concept to me.
Mm,
And yeah, I'm almost 50 and yeah, the hormones are in play and yeah, all these things, but again, I just this wasn't the case before we discovered peptides, right? Like we all weren't on these things. And again, there's something in my DNA that says dependency on anything is just a little, it makes me a little nervous. So anyway.
mm, yeah.
All right. Where were we at? Wesley, nice to have you here. She says, any concerns? No, that was we got to that one. What dose of ozone do you use for these injections when you're doing MSK?
Um,
And maybe not doses. That's kind of hard with
yeah, the
injections,
gamma or
but
whatever.
yeah, you're right. Concentration.
Like paraspinal, I'm at like I want to say 25 gamma, 24 gamma, and like 10 mLs per level. Both 10 mLs, 10 mLs. Each side gets about 10 mLs. 5, 10 mLs.
The
Yeah,
range
about
is
20.
like 10 to 30 gamma in general, and I
Yeah.
would say so you're right in the median there. And
Yeah.
I would say, and I've had hundreds of these injections, which might
Yeah.
surprise anybody. But this is also my own experience feeling them is you can get into those higher ranges of like 30 gamma. It might burn a little bit more and it depends on what you're trying to do. Are you trying to, dissect something, the fascial layers, are you
Mm-hmm.
where are you putting it, the joint space you're putting it in? Like
Mm-hmm.
somebody bigger than me, their knees can hold 10 mLs. Mine,
Mm-hmm.
I prefer 5 mLs just because I'm a little bit
Yeah. Yeah,
bone.
it's a combination of yeah, at the spine there with the yeah, like you said, at a joint I'll put in an easy 20 mLs, 35 gamma, like a knee joint can tolerate it, or shoulder joint or hip joint can tolerate a little higher gamma, and a little bit more volume, sure.
So do you do it in your trigger point stuff too? You add a little ozone there or
Um, nah, not as much.
yeah,
Not as
okay,
much.
interesting. Fine. Are you stacking red light therapy into this mix at all?
It's funny. I had slides on red light therapy, and then I took them out. I don't know why we haven't invested in a red light panel, but I do recommend people to do home red light. The red light is kind of going to offer a lot of that same stuff, but honestly, as similar as my neurofunctional acupuncture, and the shock wave, like it definitely works on the mitochondria, it decreases, improves VEGF, decreases, improves NRF2, decreases NF-kappa beta. Like it's a great complement. It's some and PEMF. I meant, that was in my
Oh, yes.
slides too. It's like that M2 micropulse thing or whatever. It's great to do at home. Really, really great for complementing all this stuff. 100% for home stuff. Um, Good. Oh, man, I do think I have to go.
You got to run. All right. Appreciate you.
Thank you so much. This was
Yeah,
great.
it's
This
so
was
nice to
fun.
catch up and
Yeah.
have you here. You've been very super educational for everybody listening. And feel free to go if you really need to go. But I just wanted to share that the Mattas and I have discussed, and I really wanted to just check with them first, and obviously, but they are offering a shadowing opportunity. We had talked through doing some injection training, some chronic disease training, and they're working on it as part of their own personal legacy profile. But they are offering shadowing opportunities, and part of the reason we went through this together was just, as you know, he has a lot of specialty in the area, as you heard. Not everybody's trained in acupuncture, not everybody's trained in fluoroscopy, not everybody's trained in ultrasound, not everybody's trained in joint stuff to begin with. And so, where does that intermediate level come into play where what he does could be useful to you? But that said, outside of a true training opportunity is a shadowing opportunity. And I'd highly recommend it. And just going into their office for a day or two. And, we got talking about it, and he talked about how much money they put in to shadowing opportunities where nobody was really guiding them through anything. They just got to observe and see things from another's perspective and another's way of operation and how it really propelled their businesses, their practice. And so, I have it here, but you can get in touch with us at Ozone Train Academy if you're interested in going to Philadelphia and shadowing him and her for that matter. Um, in terms of joints, in terms of injections, in terms of everything that we've peptides, they're really big on peptides. And agree with Dr. Seeds or not in their protocol, he stands alone. Dr. Matta does in terms of how he uses them and his understanding of them, and does teach for them, but I think he's got his own way of doing things too. And if you're a Seeds fan, then more power to you. I just know that there's some there's some opinions there. So if you're interested in shadowing him, that is one of the things I want to bring to you in these webinars is expertise and protocols, yes. But if you really want to travel and go somewhere and find something that's useful, conferences are great and the camaraderie and the networking is great there as well. But I do feel like true trainings and shadowing really gives you that hands-on and interpersonal connection that can bolster your practice in a whole different way. So if you're interested in meeting up with them in Philadelphia or close by, or maybe, and again, it's a beautiful place, historic place. His practice is very lovely. So he's offering that. All right. Thank you to you all for being here. Appreciate you following us. Appreciate you joining. Appreciate all your feedback and your support. Join our platform to get more of this insider information. We have put it kind of behind lock and key at this point, just tired of building it and losing it. And so you got to join the community. And again, masterclass on the 30th for the fundamentals of ozone and ultraviolet blood irradiation. And then our next class here in Idaho for neural therapy and EBU. And you could be new to this. You could not have, if you're just interested in EBU, you don't have the device yet, you just want to come see what it's like, then you're welcome to come for that reason too. In fact, that's probably at least 75% of the people that come here are just shadowing and learning and then trying to decide if this is an investment they want to make. So we'll have that May 14th, 15th, and 16th. And you can check out our website, ozonetraining.com, for any of the other scheduled events that we have. And we'll, of course, send you emails. This is recorded. We'll send this out to you again as the recording so you can revisit this and share it as you wish. Enjoy your evening, everyone, and we'll talk to you again soon.